Good afternoon, good evening, good morning, whatever it is for you, wherever you are. Welcome to class. This is Dr. Hess, and we're here for Abnormal Psych 239. And we are in lesson 5 today. We are going to be talking about chapter 7, which is the bipolar and depressive disorders. A lot to talk about here, some interesting symptoms and disorders that may have touched our own lives or the lives of those around us. So let me start our point here of chapter 7. So our learning objectives today, we'll be talking about how to differentiate bipolar from other symptoms, other disorders. We're looking a little bit about the prevalence of bipolar and related disorders as far as their demographics, sex, race, ethnicity, and age, etc. We'll be taking a look at the symptoms of the major depressive disorders, talking a little bit about suicidal ideation, attempts, and death by suicide. We'll be talking about some of the theories and taking a look at some of the theories of depressive disorders and some of the treatments. So here's a cute little graphic that I found on Verywell that can help us take a look at some of the, when we're starting, some of the common types of depressive disorders. We have major depressive disorder, which is symptoms of depression, lack of desire, lack of pleasure in normal things that we would derive pleasure from, some tiredness, some eating and feeding kind of symptoms, not eating a lot, eating too much, some feelings of not being confident, not being able to have anything to give, just a general down thing for longer than 2 weeks. The persistent depressive disorder is some kind of like a general down depressive mood that lasts over a 2-year period or longer. These people sometimes are kind of the kind of depressed personality. It kind of feels like that they're always a little bit down. Bipolar disorder, we'll be talking about that, where we have some kind of depression along with some kind of mania or increased in activation in our nervous system. Postpartum depression happens to women after they give birth and can be kind of severe for them when they are trying to take care of their brand new babies. Premenstrual dysphoric disorder is significant mood symptoms that occur during a woman's menstrual phase. Seasonal affective disorder, which we here in the Pacific Northwest have learned to live with pretty much. And these people are get depressed and are having depressive symptoms during the months where it is cloudy and there's not a lot of sun for us to do. So let's talk about bipolar disorder. Mania is an extreme mood with a lot of energy, there's associated dangerous behavior, some irritability if you try to talk to a person in the middle of a manic episode. They have rapid speech and they have a really sense that they are feeling really, really, really good. In order to have bipolar disorder, there has to be some elevated mood or kind of either manic or submanic episode for the person. Bipolar 1 involves full-blown mania, which is what we were just talking about with episodes of major depression. So it is the high energy state followed by a real low energy depression. Bipolar 2 has hypomania, which is some hypo means just under or lower mania. On the screen it says a mild mania. It doesn't quite make it up into classic mania symptoms, followed by a major depression. There's rapid cycling bipolar, which is where 4 or more severe mood disturbances happen within a single year. When it happens this way, then we see that the person is rapidly cycling through them and can be very disruptive, as you can imagine, for people. Cyclothymic disorder is basically bipolar light. Some people say they're lighter depressions and lighter hypomaniac phases. Bipolar onset usually is somewhere in the late teens, early 20s. Let's talk about the major depressive disorder. So major depressive disorder is basically any depression, and pretty much we all are going to have periods of depression in our life. If they are to meet the clinical symptom level of major depression, whatever's happening to us in this depressive disorder, whether we're not functioning well, aren't able to go to work, go to school, it is causing us significant problems in our life that we will need treatment in order to get better or healed from our depression. So it's a persistent sad or low mood that is causing some kind of emotional, psychological, social, or physical problems for us. Oftentimes there's eating and sleeping issues that are involved with depression, either too much or too little of either of those. Dysthymia is that kind of constant chronic state of depression, has milder symptoms, but lasts a really long time. So disruptive mood disorder is for children 6 to 18, and this is kind of how some children express their depression, is through this kind of these disruptive moods or this dysregulation of their mood, not being able to regulate their feelings either way, of either good feelings or bad feelings, but they're out of control. That's what dysregulation means. And it can cause problems, kind of look sometimes like a temper tantrum, but this would be, we probably all have had temper tantrums in our life, hopefully not too many lately as adults, but as kids, I'm sure we threw quite a few. I know I did. So this disruptive mood disorder is more than that. It's more than throwing a tantrum because you didn't get the gum in the store that you wanted or the toy that you wanted. This is something that's happening quite often at home and at school, and it's causing some problems for ourselves and for others. So we'll take a look at some of the developmental factors of depression and major depressive disorder. The mean age for onset of major depression is 26, and which is kind of interesting when you think about it. When you think about that, that's the same age that the researchers are telling us that our brains have finished forming, and at around 25, 26, 27. At least that's what they're saying now. And also, according to current federal law, this is the time when you can no longer be on your medical insurance of your parents. So you are an adult having to do adult responsibility things at this age. And here you go, the mean age for major depressive disorder. I won't connect the dots for that for you. You can if you wish. Depression can happen at any time. As you see at the end of this slide, about 20% of adults in later life, 50 to 64 years old, will have depression, and about 10% of those 65 or older will have a major depression that will require treatment or medication. Depression is something that happens a lot with other disorders, and there's comorbidity that co-occurs with several medical conditions, anxiety disorders, substance abuse disorders. We see a lot of depression and associated with major surgeries such as heart valve surgery, any kind of open heart surgeries. We see there's a lot of post-surgery depression that occurs. There's a lot of depression that occurs in the eating and feeding disorders. There's some genetic research showing that there's an influence and a risk for major depression and generalized anxiety disorder together, running in families. Oftentimes, when we're left with a low mood and a major depression, we're not feeling like we have anything to give. We can't really see hope in the future. It'll lead to thinking about thoughts of suicide, or maybe passive suicide, which is maybe driving too fast, or you doing risky behaviors that might cause us to die earlier. Suicidal ideation is basically something that probably most of us have contemplated in some way or form during our life, and that is basically thoughts of our own death. The passive suicidal ideation is where we kind of wish we were dead without actively planning it, whereas the active suicidal ideation is basically thinking of the details of how we would commit the act, having a plan of how and when and where we will commit suicide. About 90% of those who attempt suicide or die by suicide suffer from some psychological disorder. So there's a big correlation here. About 70% of those who attempt suicide have had a mood disorder in the past 12 months. A lot of anxiety, agitation, and impulse control problems are associated with those people who attempt or complete suicide. So in the prevention of suicide, it's important to know that kind of psychoeducation, kind of learning a little bit about suicide, and being able to have access to support via means of the crisis intervention suicide hotlines, being able to talk to other people in our lives about our mood and about our thoughts, and kind of helping those around us, giving them support when they need it. So the psychodynamic theory, Freudian theory, explains depression as anger turned inward. In other words, when we are angry at something that's happening in our life, rather than being angry at someone or something in our life, we don't feel like we can do that. And so we turn that anger on ourselves and blame ourselves. This pushing down of that, the anger, the depressing of those feelings that we have ends up giving us depression, and can result in a major depressive episode. Those when we have disruptions in the attachment, in other words, our primary caregivers, those people that are with us and that we consider to be support figures in our life, when there's some kind of disruption or we lose that person, oftentimes we can become depressed and do this. We've studied babies. When their mothers are taken away, the babies will often stop eating and become depressed and die. Behavioral theories basically say we learn or model off of other people around us how to be depressed. We don't get reinforced for the good things in our life, and we learn that no matter what we do, that learned helplessness, no matter what we try, what we do, it always turns out bad for us, so why try? So CBT, again, is our treatment of choice, along with some other psychological talk therapy treatments. For bipolar, lithium is still a commonly used medication. Lithium is a heavy metal, which is used to help regulate moods, and is used long-term in people who are suffering from bipolar disorder. Anticonvulsive medications combined with lithium is also used. We also use ECT or elective convulsive therapy. Medications are used. There's a high suicide risk when working with people suffering from bipolar disorder. And oftentimes medications aren't used because they can be used as a mode for attempted suicide. So when we're talking about depression and we're looking at someone and trying to make that differential diagnosis of what's going on with the person, we want to make sure that they have a comprehensive physical exam, because a lot of physical symptoms can appear and represent in a person looking like a psychological depression when actually there's a hormonal problem, or actually there's some kind of physical problem going on with the person. And so no matter how much talk therapy or how much psychotropic medication we give somebody who has a thyroid problem, for example, they're not going to get better until the doctors are able to treat their thyroid dysregulation. So the biological treatments for depression, we have the first generation antidepressants. These are tricyclic antidepressants. And they still are used. They work well. They basically prevent the reuptake of neurotransmitters such as norepinephrine and serotonin. The second generation are the selective serotonin reuptake inhibitors, or the SSRIs. These have fewer side effects than the first generation medications. There's electroconvulsive therapy, which is shock therapy, which has become somewhat more popular recently with the ability to use computers and high-tech microvolts, being able to specifically target certain parts of the brain and giving them a little bit of a shock has helped people get better from their depression. Being exposed to light has been, and they sell these light treatment lamps all over the internet for the seasonal affective disorder, or SAD. Some of you may have one of these at home if you live in Portland or some cloudy area. There's transcranial magnetic stimulation, which is the use of high-powered electromagnetic pulses and energy sources close to the skull, and again, focusing on certain parts of that. There's also deep brain stimulation, where through psychosurgery, where they implant electrodes in the brain to give a little bit of a jolt to the brain, and is implanted and stays there, somewhat similar to the heart shock machines that people wear to help their heart continue to beat at a regular basis. Oh, we've come to the end of our lecture today. Continue reading our chapters, take a look at our syllabus to see what's due today. The discussion boards are going great. Keep all that good work up. I really appreciate your continued work in the class. And I love reading your assignments and taking a look at your discussion posts. Thank you again so much for joining us in our class. I hope you're staying curious about our disorders, and I will see you next week.